Hi. Okay, welcome back with our next video or the last video for this OPT 3475 low vision and further optometric care. So now we're going to look at the final part of everything, which is going to be the management. Okay, although all this while we have been looking at the management also, okay, what are the options that are available? Okay, so now we're going to actually look at, um how to actually perform the management on patient. Okay, before we move on to that procedure, we're going to look at um, some left out management that was not discussed in the previous, lectures. Okay, so they're going to look at that. Then we're going to look at how to actually uh, do management for this visually impaired person in the clinic. Okay. So first, when it comes to low vision patients, okay, we need to increasing the object size is one of the important management that we have to do. Okay, uh, additional to the magnifiers. Okay, if let's say the magnifier is not working, then increasing the object size is one of the important management that need to be given, and it's actually applicable for school going kids especially. Okay, the advantages of these large printed materials is it actually helps them to have a normal reading posture and binocular use. Okay, it's easy to use, no training or special skills is needed because it's just enlarged printed materials. No cosmetic concerns or optical distortions. Okay, like if we provide magnifiers or high class reading glasses, that is going to affect them in terms of the cosmetic and also cosmetic concerns and also optical distortion. So no such thing. And then can be used without professional input. We don't need to actually train them to use this like magnifiers. Okay, they can just use that without any training. But the disadvantages would be the books become bulky and harder to carry. Fewer words per line or more eye movements are needed. Okay, limited magnification, usually it can be enlarged up to 2 times or lesser than 2 times. Okay, limited book selection, mostly fiction and few educational or reference book that can be printed out like this. Okay, photocopied materials have poor contrast, low quality images. So it's not going to be as good as the original version. May limit reading speed development compared to using optical aids, because optical aids, you have to move quickly to read, but this one, because of the eye movement that we have, it might be affecting the reading speed. Okay. So when it comes to these large printed materials, right, when we compare the usage of this between the children and adult, okay, the aspect of ease of use, children, it is more practical in fast paced classroom settings. Okay, while for adults, it's suitable for independent reading without needing training. While for in terms of reading speed, expect, okay, may plateau up over time. That means it becomes stagnant over time. Okay, adults similar performance to other magnification methods. Okay, so these children will have the similar reading speed, while adults will have the similar performance when they use other magnification methods also. Okay, access to print limits exposure to general print outside school. Okay, for children, okay, they limit exposure to general print outside school, still may not support tasks needing distance or intermediate magnification. Okay, it is not going to actually support the need in distance or intermediate magnification for adults. Okay, in terms of book option, very few age appropriate or teenage fiction titles that is available in this large printed materials, while for adults limited technical or reference materials are available for them. Long-term benefits, slower improvement compared to optical aid users, because optical aid users, they will actually try, the eye movement is lesser. Okay, so they will read far, the improvement can be seen more in optical aid users. Okay, convenient and acceptable for mild visual impairment. If let's say it's a severe visual impairment, then this large printed materials will not be helpful. Okay, so this is the difference, between the children and adult. Okay, so other options that we can actually give is ebooks. They can zoom in when they read. Okay, it's quite common now with the usage of tabs, iPads, and all that, right? So it's easier for the patients to read. Large text on the computer also the same. We can zoom in the document, especially if it is coming in PDF form, right? Or even Microsoft Word document also, we can just zoom in to read. So that is applicable for visually impaired person. And then decreasing viewing distance. Okay, so the management in the low vision. Okay, the first one is we increase the size. Next, we increase the viewing distance. Okay, by using this handheld magnifiers, stand magnifiers, high plus lenses, right? It decreased the viewing distance. That means we go closer, and then with the help of the lenses we magnify the images and then enable us to read. Okay, the next option that is available, okay, when it comes to management of low vision is electronic devices. Okay, so we do have desktop electronic vision enhancement systems like softwares, where it can actually make, verbal explanation when, click on any icon button. So when the cursor moves, right, it will actually give a audible, voiceovers. Okay, and then television and mouse based magnifiers, where the mouse, when we move the mouse, okay, on the desktops, right, okay, whenever the mouse goes, right, that image on that particular, when the cursor is over there, then it will actually get, the image is actually can get bigger. Okay, and then we do also have this portable EVES. Okay, the video magnifier kind of thing. Okay, so that is also helpful for the patients. And also now we do have this wearable and head mounted kind of VR kind of thing, so that enhances the vision of the patient by magnifying the images that is seen by the visually impaired person. Okay, okay, this EVES is is the software and also the video magnifiers. Okay, so this is the new name of it, like we call it CCTV, now they call it as EVES. And then we do also have management in making the angular magnification bigger, that is through the telescope. Okay, telescope is one of the examples of managing low vision patient. Okay, with EVS, sorry, with telescope, angular magnification. And then also other management that we give this low vision patient would be the contrast and glare. Okay, so contrast and glare is through the adaptation to the environment as we see in the um, um, previous lecture. Okay, visors and shields for patients who are having glare problem. Pinholes, this is still doubtful whether the pinholes helps or not. Okay, but there are some options for the pinholes. Okay, that can be provided to the patient. And then also, this pinholes is usually prescribed to patients who are having, pupil, the shape of the pupil is, bigger than what they're supposed to have. Then this patient usually will have extreme glare problems. So pinhole lenses will help them, but it is going to affect them in others, not in all conditions. Like if let's say they wear these pinholes during the, in a dim light illuminated places, then it's going to actually affect their visual acuity. Okay, so it has to be, prescribed according to the need. Okay, next is artificial iris contact lens, for patients who are having again iris problem, okay, bigger in size or not in good shape. Okay, then artificial iris contact lens can be actually prescribed. And also for patients who are having pale, depigmented iris, they also can be prescribed with this artificial iris contact lenses. Okay, so that the amount of light that goes into the eye can be controlled, because they don't have the natural sponge, which is the iris, to absorb excessive lights. Okay, so that can be uh, helped. Okay, and other way of helping patients with contrast and glare problem will be stethoscopes. Okay, for them to be able to read, using the stethoscope. Tinted lenses, tinted contact lenses can be provided to see whether the contrast can be increased or glare can be reduced to the patient or not. Okay, is there any particular way that saying that, okay, this tinted lenses is good for A, this tinted lenses B is good for, you know, B? No. Okay, it is all try and error. If let's say you have like a trial tinted lenses, so you have to try with the patient and see which one is the one that works best with them. Okay, and then we make the order. Okay, we cannot simply prescribe them with any tinted lenses based on the recommendation from the supplier. Clinically, it doesn't work. Okay, they might say that this particular tinted lenses A, it works the best for this problem A, but then in reality, not all patients are going to be benefiting from that, because when it comes to visual impairment or low vision, right, it is not caused by one particular ocular condition. Okay, there are multiple, ocular condition that will be involved. So it might work for condition A, but it is contradicting with condition B. So that is the reason why it is advisable to try the lenses and see whether the patient is actually seeing with a better contrast or with a better acuity or not with the tinted lenses. If yes, there is improvement, then we prescribe. Otherwise, we just ignore, don't prescribe any. Okay. And the next one is, the next management that we give to low vision patients are illumination and lighting. Okay. So illumination and lighting are one of the important changes that we have to make, if let's say the patient is having this glare and contrast problem. Okay. So number one is ambient illumination, maximizing daylight, artificial lighting, effect of room color on lighting, and uniform lighting levels. Okay, so this ambient illumination, right? Okay, the options that we have is we maximize the daylight. Okay, how do we maximize the daylight? Is to have the windows are all open without any curtains, to increase the illumination in the house. Or we can actually, increase the illumination by using the artificial lighting. Okay, effect of room color on lighting, like if let's say, the room is painted in white color, then it will give a brighter illuminated, feeling for the patient. And also uniform lighting levels. It's not like one side is like yellow light, another one is like white light, another one is like a, warm light. So it's going to be confusing, and also the contrast is going to be affected. So if let's say that area is going to be fitted with warm light, then the whole room is to be in the warm light. Okay, so that the uniform lighting levels is also similar. Okay, and that gives a better ambient and also a better comfort for the patient. The next one is localized task lighting, localized lighting. Okay, like a table lamp. Okay, the light positioning, like as I mentioned earlier, not on the side of, where, patient used to write. It has to be the opposite side, and the lighting position has to be facing the reading material or the writing material, not the head or any other parts of that area. Okay, so lamp design, okay, that is also important. Okay, it is always advisable to use a flexible one so that we can adjust the position. And portable lighting option is highly recommended. Okay, like table lamp and all that, instead of the ceiling light, because that might cause a shadow when patient is actually, doing some reading or any near work. Okay, and also lighting for outdoor mobility, like using a pan or torch, using the handphone lights. Okay, especially for those who are having rods problem or degeneration. So this patient would have problem in actually navigating in a dark illuminated places. Okay, so with this two additional lighting, that will actually help them in terms of the mobility. Okay, so another management in low vision during the low vision consultation is would be the aids for peripherals. So as we already discussed, we do have field expanders, reflecting system, okay, mirror reflecting system, and prism. So we don't forget patients who are actually having visual field defects also in the management. Okay, so it is equally important as how we prescribe the glasses for the patient. Okay, so that shouldn't be ignored on the patient. If let's say the patient is not having any uh, visual field defects, right? Okay, then we can ignore this. But if let's say they have, right, we try to find out how we can help the patient with. Okay. And the next one is the special training techniques for visual field loss. Okay, like central visual field loss, we actually train patient with eccentric viewing training, which we already discussed. And patients who are having hemianopia, yes, as the previous slide, we do have options for that. And also we do provide training like visual exploration or visual scanning therapy. Okay, how to do this therapy is very easy. Okay, it is just that we need to advise patient to have more head turn, okay, to the maximum, okay, so that they know what is actually available in the front. Okay, while they're walking around, while they're moving around. Okay, if you've seen patients, if you've seen any visually impaired person at outside, right? Okay, if you see, if let's say they're using white cane and all that, right? The head will be moving right, left, right, left. Okay, there is a reason why they have that. Okay, they have a very limited vision. Okay, they try to move their head and grab, as many as possible of information that they can see with their blurry vision that they have, and then at least they know what is actually, in front of them, or in the environment or the room that they are in. Okay, so the same thing we advise for patients who are having hemianopia, like temporal visual field loss and all that, right? So they can actually have their eye turn, because if let's say we want to know what is the side, we just need to move a little bit, then we get able to see. But this patient have to make a full eye turn, sorry, head turn, to see things. Similarly, when if let's say they want to look up, look at the side, okay, if let's say they have like a inferior field loss and all that, right? So these patients, all they just need to make a big head movement. Okay, so that can be taught to the patient. If let's say something fall on the floor, they have to make a full turn, okay, so that they can see, scan through to look at the things that has fallen down. Okay, so additional to that, once they already start having the habit of like turning their head to the max, okay, the next thing that they can do is they can plan they can play table tennis. Okay, table tennis is one of the, okay, why, okay, once they already doing that scanning, right? Okay, the next thing is we want the scanning to be quick. Okay, if let's say something is actually coming and hitting them from one side, they have to respond quickly. Okay, so to get the quick response, we encourage them to go for a table tennis. Okay, just play table tennis, because when they actually hit the ball, okay, when the opponent actually hit the ball again, the duration of the hitting of the ball from this side to the other side, and the response that we get from the other side, right, it's very quick. So they have to be ready to actually hit the ball when they receive it. So the head movement has to be fast for them to react to it. Okay, so that will actually make them to have a quick response. So if let's say they feel like someone is coming from the side, they have to make a quick hit turn rather than do it slowly. Okay, so this table tennis is going to actually enhance the visual exploration or the scanning technique, that we trained up. Okay. Okay, next management is the rehabilitation technique for nystagmus. Okay, as I already explained earlier, the null zone training is one of the management that we give to the patient, and also sensory substitution management. Okay, like smartphones, digital assistants, and apps, which I already discussed earlier. Okay, personal communication like tactile methods. auditory methods like microwave oven, which comes with auditory, cues. Okay, comparator access via speech and braille. Okay, when they move the cursor, then the voiceover will let you know where the cursor is actually being placed to. And then mobility, we do have guide dog. Okay, in Malaysia, there is only one person who is actually having guide dog in Malaysia, and that person is Mr. Stevens Chan. He's the president of Glaucoma Society in Malaysia. Okay, so he actually got. We don't have like a training center for this guide dog. Okay, he went to UK or US. I'm not very sure. And then getting a guide dog is not easy. Yeah. Okay, these dogs are actually this breed is actually a special breed. Okay, where they actually, they have like special qualities, like they're very close to their owner, they're very obedient. Okay, and they have like a few characteristics. So only this particular breed dog that can be used as the guide dog. Okay, and they do have like a center in that place where they train these dogs. Okay, so once they get the owner, so what they will do is this owner has to spend like months with the guide dog, okay, to be with them, and then they will be protecting the owner, the guide dogs. Okay, they will do all the activities while they're walking. They'll make sure that there's no obstacle in front. Okay, they know how to give cue uh, to the owner, and they know how to behave in the. They don't bark. Okay, if you see here, these guide dogs, they don't bark. Okay, they only bark in certain situations, and that also it's understanding between the owner and also the dog. Okay, so it's a very loyal dog. Yeah, so it has to be trained. It's not like simply get any dog and you can have it, and then you have to have license over there to have the dog, because and this dog is not harmful. It's not harmful. Yeah, okay, because you can bring this to outside, in public areas and all that. But in Malaysia, they are, although he got the license, but it is very restricted. Only at certain places that this dog is allowed in Malaysia. But in other countries like UK and US, this guide dog is kind of well established over there. In Malaysia, there is only one guy having it. Okay, as per my knowledge. But now I don't know whether anybody extra having this or not. But Stevens Chan is the only one. So that is more mobility. And then next one is uh, sighted guide technique. Okay, sighted guide technique will be, to teach the family members or the caretakers on the right way of guiding the visually impaired person to move around. If let's say they're not using any white cane, so that they can actually move around, in a safe, in a more safe manner. Okay, so and also they have white canes, okay, for mobility training. And this white cane training, right, it is provided by MAB St. Nicholas Home. Okay, so they have like a special trainer for it. Yeah, okay, so this white cane training is not like you can get, okay, you can buy the white cane, but to use it confidently, you need to actually attend the training. Okay, and also the white cane, right, there is a measurement, according to the height, and you also have to get the correct white cane, and also attend the training before you can use them in public. Okay, why is it, what kind of, because I went for a training where they taught us this, okay, on how do they train this white cane for visually impaired person. It is actually very interesting. Like for example, they will have a room, empty room, and then they will teach this visually impaired person on how, when they go there, right, they will be blindfolded when they are being taught, because they don't want them to have any other sensory that is involved in this. They don't want the vision to be involved. It's all about the hearing that they determines, what is the obstacles in front of them. So they will have an empty room, and they have to tap the wall and walk to know how is the shape of the room, first of all. Okay, so that is the basic one. And then when they walk, they will be taught on how to walk and how to tap on the floor and how to listen to the noise and predict, what is awaiting for them. When they cross the roads, they have to um, wave the white cane. That also will be taught how to listen to the traffic light sound, and how they have to move, okay, without any mishap happening to them. So it's a very interesting um, training, okay, which is actually very will be very beneficial for the patients. Okay, there are patients who will be very reluctant or hesitant in actually and attending this course or be learning this. Okay, we as an eye care practitioner, we have to tell them what are the benefits that they get. Okay, especially young kids, right, who already lose their vision. The parents will be very skeptical in in deciding whether to send the kids for white cane training or not. I would highly recommend this, because when a patient is actually, already blind or going to be blind, right, it's good for them to learn this white cane, because they can be independent in their life. Okay, only up to certain years the parents can take care of the kids. But once they are not in the world anymore, they have to be independent. So it's good that they start early, okay, so that they can actually, by the time they're still young blood, right, they can learn things. Okay, and then once they're be able to move independently, right, they will be more confident in doing things. Okay, so starting a little bit difficult in the initial stages, but if you see in the MRTs, in the roadside and all that, right, people are just visually impaired person using white cane like nobody business, and doing things very confidently. Okay, so that is very good. Okay, next is trailing trails, for them to move around. Okay, ultrasonic and laser. This is not so famous in Malaysia, but they are there in in other countries. Okay, next one, the interesting one is the sports for individuals with visual impairment. Okay, a lot of parents, especially school kids who are going to normal mainstream schools, right? They don't know that actually their kids can play sports. Okay, so this can be suggested to the parents. Okay, sensory substitution is a key in adapting sports, like rather than using their vision, they use some cues, touch, sighted guide. Okay, so there are certain sports that is already adapted for this method, like tandem cycling, guided running. That means they will be tying hand with the guide, who can run faster than them. Okay, but they will run with the space, with the pace of the visually impaired person. Okay, swimming with tappers. Okay, you can Google for the videos. There are many videos on this. Okay, sound producing balls and modified rules like blind cricket. Okay, with the ball have some sounds. Okay, special equipments like foot locators, tactile sights, for archery. So it doesn't mean that if you lose your vision, you cannot do any of the sport. There are a lot of sports that is being adapted, and there are Paralympic sports events that happens quite aggressively for this, not only for visually impaired person, but also for other special populations also. Okay, so disabled patients. So there are a lot of uh, privileges for these kids and also opportunities. Okay, so equal opportunities, blindfolds used in some sports for fairness, like goal ball and all that. Okay, it's like a football with a ball with a sound, okay, with a bell inside, when so they will chase the ball based on their hearing sense. Okay, so that is why it is called sensory substitution. So substitute the vision to the sensory. So what are the barriers and opportunities in sport participation? The benefits is obviously the physical and mental health, and social, because they get to learn, get to know more people. Okay, the barriers is limited access, lack of awareness. Many people don't know that blind people or visually impaired people can actually play sports. Okay, transport challenges. Okay, need for sighted partners, like certain activities need guide runners, and they have to get the one that gel with them. They cannot simply go for anyone. So all that is actually the barriers. Okay. Okay. And also, since we are talking about the sports in visual impact person, right? So we have to know the classification in competitive disability sport. Okay, there is a classification, as I mentioned earlier. We do have like a Paralympic classifications. Okay, where when you want to attend or participate in any sports, you have to you have to go for the classification. That means visual assessment. Okay, physical assessment will be conducted to see how much you are disabled and what for this kind of disabilities, what kind of sport that you can join. Okay, and that is the purpose of it. So group of athletes by level of vision impairment to ensure the classification is to group the athletes by level of vision impairment to ensure fair competition. Like for example, like the goal ball I mentioned just now, right? It's a football, okay, but for visually impaired person is known to be the goal ball. Okay, so to make sure that the equality is there between all the competitor, so they are blindfolded. Okay, so this classification is important for that, so that everybody gets the equal opportunity. Okay, equal opportunity means if let's say there shouldn't be an advantage in if let's say the patient is low vision but the VA is 660, another person is 360, so that is not equal. So that is the reason why these peoples are grouped, so that they can actually see that they are, I mean, the classification is already set. So if let's say you have this VA, then you can participate in this activity. If let's say you have this VA, then you can participate in. If let's say you have this VA, okay, A and B like large, but if let's say you're blindfolded, you can play this sport. So there are a lot of standards. Okay. Okay, standardized system based on VA or visual field, worst result is used. That means the most damaged one. Concern some classification across sports may be unfair. Okay, shift to sport specific classification based on how vision loss affects performance. Okay, uses stimulation to test minimum impairment criteria, like in rifle shooting, right? All visually impaired athletes used auditory cues. Vision didn't affect outcome. That means that patients who are actually have disabilities, they will be blindfolded anyway. Okay, so with that, everybody has the equal opportunity. So this is the visual acuity and visual field criteria for classification of visual impairment used for competitive disabilities sport. Okay, the standard is which if either the visual field or visual acuity criteria are met, in Snellen acuity is lesser, is used to indicate worse than, and more than indicates better than. Okay, so this is how they are classified. Okay, so B1 is like the worst. Okay, no light perception, or they have light perception or perception of movement, while B2 is like 260 up to um, 6 1.5 logma. Okay, so the rest is the same. So these are the ways of classifying the patients for the spots. Okay, so if let's say you fall into this category, then you have to do only certain, you can play only certain games. Okay, but if let's say certain games, you can have both B3 and B2, but both of them will be blindfolded, so the vision is not a factor. Okay, so this kind of things also taken into consideration into the classification. Okay, now we already look at the management option. Okay, for past 5-6 videos is all about management. Now look at how do we manage the patient. Okay, please do take this slide, mark this slide, because this is the most important one. How do we manage patient? How are you going to practice this in the future? Okay, first of all, any patients that comes into your clinic, you have to explain the condition of the patient. What is the eye disease that they're having? How the eye disease is actually causing them to have the sign and symptoms that the patient is having. Okay, that is number one. Okay, then next is what are the assessment that you have conducted and what are the findings that you get? Only the one that problems. Okay, the rest no need to inform. If let's say the vision, VA is not good or anything, all the assessment, explain to them one by one. Okay, the problematic one. Okay, we did visual acuity. Okay, we tested on how good you can see at far. We found that seeing far is definitely affected so much. Okay, but seeing near, we found that it's still doing good. So explain in a very layman term of all that assessment that you have conducted. And we found that when we do the assessment using the machine, right, that we shine light, we found that, you have dryness in your eye. So that's how you explain to them in layman terms. Please do not use optometric terms to explain to the patient. Okay. Next is low vision devices. Okay. If let's say you attempted, then you have to tell the patient, we attempted and we found that this is good. We attempted, or then another way is it, we attempted, but it is not helping you. Even we tried, increase the magnification or increase the power, but still this low vision devices is not helping you. Okay. Then comes the non-optical devices. Okay, if let's say they need any, you explain to them that this will be helpful. Try to use, okay, since we are prescribing you with magnifier, okay, try to use a stand reading stands to place your reading material so that you can actually move forward rather than you bend down while reading, which might cause your back pain. So please do that. And then rehabilitation. Okay, so we just looked at the previous video on all the rehabilitation and see what you can help, okay, in terms of the rehab. And also multidisciplinary approach. If let's say you need to, okay, for example, you say you think that this patient needs to do certain ADL, but it is not under your scope, then you refer them to occupational therapies. Okay, so whatever that is needed, like if let's say the patient needs counseling, if let's say the patient needs need to be checked by the ophthalmologist, just refer them. Okay, and then you counsel them. Okay, counsel them what they have to do. Okay, how to protect their eyes. If let's say they have any doubts, anything they can ask. And then once you're done with the counseling, then you go for follow up. Okay, so the follow up will be when they have to come back for the management. Okay, is it 3 months, 1 week, or 1 month, or 6 months, or 9 months? You have to let them know. And also at the same time, you have to let them know why you're asking them to come back. What are you going to do in the next visit? So that patient will be compliant to the appointment that you are giving them. Okay, so it is you have to tell them in detail. Okay. So that's all for this lecture. I'll just go through again what we learned in the management. So in terms of the management, there are many management that we have actually um, learned for the past, in the past videos. So this one is just summarizing what are the options that is available. Okay, number one is increasing the object size for the patient. Okay, number two is decreasing the viewing distance. Okay, by moving closer, then it makes things clearer for them. Okay, by using electronic devices and apps, and that angular magnification, through telescope, contrast and glare management, illumination and lighting adaptations, okay, according to the condition of the patient. And also there are aids for peripheral visual field loss, and also training for visual field loss, both central and also hemianopia. And then rehabilitation technique for nystagmus, okay, null zone training that we provide. Sensory substitution, how to replace the vision with other sensory to take place so that they're able to do their daily activities to improve the quality of life. Okay. And then we also have solution for the not solution management for the spots for individuals with visual impairment. So gather more information related to this, get updated by time, in future for you to let know the parents, or let know the patients that you can still do sports activity with this limited vision. Okay, and then barriers and opportunities in sport participation. We also look at we do have a classification team, okay, for sports, and this is the way of classifying them. And then we looked at the management procedure, explain about the eye condition based on the problem that they have in the eye, and also the how is it related to the complaint that they are having, and then do assessment. Okay, explain the assessment. What are the assessment that is actually need to be performed? sorry, not need to be performed. What are the assessment that is performed and what is the outcome? Okay, only discuss the one with problems only. We did this and we found that this is not really good. Okay, so explain the abnormal findings only, and then discuss about low vision devices, whether you're going to prescribe. If yes, for what activity. If you're not going to prescribe, tell, no, and then why. Okay, and then non-optical devices, as per the complaint of the patient, need to be discussed. And then the rehab, as what we have looked in the previous videos. Okay, there are many rehabs. Okay, so whatever that you can do, okay, you do that. And if, let's say, something that cannot be done, then you have to actually refer them to the correct professionals, and also counsel them, okay, regarding this. And then you follow up with them, once everything is done, all the explanation, tell them what is the follow up is for, when is it going to be, what are the assessment that will be conducted, and why that need to be done, need to be explained to the patient in detail. Okay, okay, that's all. Thank you.